Well, good evening, everybody, and welcome to a new experience for us here in San Diego County, our first ever virtual town hall forum for clinicians. My name is Dr. Nick Efantides. Tonight I'm simply Nick, and I serve as the Chief Medical Officer of San Diego County. And I am blessed to be joined by several of our regional colleagues that I will have introduce themselves in just a moment. But before I go there, I want to just give a couple technical guidelines and instructions with regard to how this event tonight is going to work. Your lines currently have already been muted, and they will remain so throughout the initial part of the presentations. Throughout the telebriefing, hopefully there's a spot on your screen where you can ask questions by typing them in using the Zoom platform. Those questions will then be printed, and I will be receiving them, and when we get to that portion of the event, we will be responding to them accordingly. And then for those of you who are connected through the online web link, we encourage you to submit questions throughout the presentation. And again, we will come back and address those at the end. Just to make a couple quick comments, please, and then I'll have a few more. There are hundreds of you that are logged on tonight, and this is a very special opportunity for us as clinicians to have a place to really have an open dialogue. I believe very strongly that in the presence of trust, transparency, and data-driven decision-making, that amazing things can happen. And we are facing a very unique and new challenge. What I've enjoyed telling my colleagues and my family is that we, I believe, are now making and living through history. And with that in mind, before I go any further, I'd like to just go down the line and have each of my fellow colleagues introduce themselves, what their roles are, so that you all know who the participants are tonight on the webinar. And I'll start with you, Eric, please.
Sure. I'm Dr. Eric McDonald. I'm the Medical Director for the Epidemiology Program for the County of San Diego and also the Communicable Disease Control Officer for the county.
Good evening, everyone. My name is Dr. Wilma Wooten, and I'm the Health Officer and Director for Public Health Services in the County of San Diego Health and Human Services Agency.
I'm Dr. John Bradley. I am a pediatric infectious disease doctor, the Medical Director of Infectious Disease at Rady Children's Hospital, and part of the faculty of the UCSD School of Medicine Department of Pediatrics.
I am Francesca Torriani, and I'm the Program Director of Infection Prevention and Clinical Epidemiology at UCSD Health. And I am an infectious diseases specialist in the Division of Infectious Diseases and Global Public Health.
I am Andy Parr, and I am not a physician, but after 40 years in the fire service, I've come to the county as an emergency management expert and overseeing currently the EMS program for our county.
Can't tell you how grateful I am to each of you, especially in the midst of our hectic schedules, for making the time to join us here tonight. A few introductory comments, folks. Tonight is a special event that is a reflection of an intimate level of collaboration and partnership between the county and San Diego County's Medical Society and the Hospital Association of San Diego and Imperial County. This event was planned collectively between all three entities, and I think it is fair to say, without any exaggeration, that in all the years that I have been here in San Diego, including when it all started as a medical student back in 1987, I have never seen the level of alignment intimacy and collaborative spirit that currently exists between the county and the organizations that I just mentioned. The opportunity for us to all be on the same page, working together, especially when it comes to a situation like we are now facing, is ever so critical. There has been seamless collaboration in terms of the messaging that the Medical Society has put out. For those of you physicians in our community who are not yet members of the Medical Society, this is a perfect example of one of the many benefits of being part of that organization, which I believe, especially in the coming days, is going to be even more important. And then we are blessed with an incredible network of health facilities, hospitals, that in the spirit of what we have going on now are working very closely both with each other and very closely with us at the county level, and I just want to quickly acknowledge that. Secondly, I want to say that San Diego County is a regional innovation zone. We have some things going on here in San Diego that are truly not only best in class, but I would say do not exist in any other part of the country. We have a very robust and meaningful health information exchange called San Diego Health Connect that I hope all of you are familiar with. If you are not, you should be. And I believe, again, in the context of what we are dealing with here, it is an incredible opportunity to step up both the utility and the strategic impact that that kind of regional health information exchange can have. We are also blessed with a very robust resource we call 211 that is available to our community to use. It is there at all times. It is also something that especially is more relevant to our current general public during the circumstances that we are facing. I also want to quickly say that while this is a meaningful challenge for us that we are facing on a regional level, I think it's fair to say that we are, quote unquote, battle tested. As a region, we have gone through some incredible things over the course of the last few years. I know you're all familiar with the hepatitis A outbreak and the amazing regional response in collaboration, again, with all the partners that I have mentioned that responded to that in such an appropriate and strategic way under the leadership of Dr. Wooten. We also, just in the past 12 months as a region, came together and responded to a very unique and unprecedented migrant health challenge with individuals who were seeking asylum and ensuring that they receive the care and services and support that they need, not only on their behalf, but also in protection and in wellness motivations for our entire community. I also feel very strongly, and that is my own background in terms of the clinical context in which I come from, is the amazing safety net that we have in San Diego County of an incredibly sophisticated and high-quality network of federally qualified health centers, those that are part of the health center partners as well as family health centers of San Diego. San Diego not only has been through a lot, but San Diego has a lot of resources that I am confident we will do the best that we can and be proactive in our region in order to respond to the challenges that we, I believe, are going to meaningfully face in the days ahead. The last thing that I want to say before I turn it over to Dr. Wooten is a little bit more personal. Folks, I'm so thankful to have the opportunity to be serving in this role as your region's Chief Medical Officer and now working for the County of San Diego. I started in that role in 2009. I'll never forget the day. It was April 1st. And I assume all of you recall that not long thereafter, in 2009, during very much an off-season for us, we faced another regional challenge, and that was the pandemic of H1N1, also known as swine flu. My own father, George Fantidis, was the third confirmed fatality related to H1N1. And so a lot of the passion and enthusiasm and motivation that I have being in this position at this time is fueled not only with my heart for my community as a clinician, but also with passion and love to honor the legacy of my own dad. And I say that with intentionality because, folks, we are all human, and I am aware, as recently as emails that I've gotten today, that there may be many of you as fellow clinicians out in our community who potentially are facing the reality of the magnitude of what we are going through. You have concerns not only for your own health, but obviously as your own health as it relates to the health of your loved ones, your children, your parents, your spouses. And so while we have this space tonight as clinicians to talk about clinical issues, I also want to acknowledge that we are in this together as human beings with love for our community, but also as human beings with love for our patients, but also, and perhaps most importantly, as human beings with love for those that we are closest to, most responsible for. And I just think it is important for us to be mindful of that, to be able to accept that, and to be open about that. I believe in the concept that vulnerability and authenticity breeds receptivity. And my last thing, before I turn it to Dr. Wooten, one of my favorite quotes of all time by one of my favorite authors, C.S. Lewis, who authored the Chronicles of Narnia, among many other things. He once said that the beginning of true friendship happens when one person says to another, "What? You too? I thought I was the only one." Part of my motivation for working to prepare and put together tonight's event is for us to have that spirit of, "What? You too? I thought I was the only one." So those are my comments, unscripted and from the heart. And with having laid out that framework, I would now like to turn it over to my colleague, who is the Regional Public Health Officer for San Diego County, Dr. Wilma Wooten. Thank you.
Thank you, Dr. Nick, and good afternoon or good evening, everyone. So I'm going to provide an overview of basic information about coronavirus. Coronavirus actually is a common virus that can infect your nose, sinuses, and upper throat. The coronaviruses are named for the crown-like spikes that occur on the surface. Common coronaviruses usually cause mild to moderate symptoms, much like the common cold, and these illnesses usually last for a short period of time and can include symptoms such as runny nose, headaches, cough, sore throat, fever, and a general sense of malaise. Most people get a coronavirus infection at some point during their lives. Coronaviruses are common in many different animal species, but most coronaviruses do not infect humans. On the rare occasion, however, coronaviruses can evolve and infect humans and then spread from person to person. As we know it today, there are 7 coronaviruses that can infect people. The first 4 are responsible for the common cold, and I've provided the symptoms associated with the common coronavirus. There are newer coronaviruses that have infected humans over the past 2 decades. The first is the Middle East Respiratory Syndrome, or MERS, and the second is Severe Acute Respiratory Syndrome, or SARS. And you may recall the outbreak associated with SARS in Canada in 2003 and 4. And now we have this new or novel coronavirus, which is SARS-CoV-2. and it is responsible for COVID-19 infections. The novel or new coronavirus that was identified and that we are talking about today was actually identified in Wuhan city in China and in late December last year. The virus is now spreading from person to person, and Dr. McDonald will talk about our cases, but we are confident that we now have community transmission. On March 11th, which was last Wednesday, just 1 week ago, the WHO designated the COVID-19 outbreak as a pandemic. So this virus probably originated or emerged from an animal source, but now seems to be spreading from person to person. It's important to note that person-to-person spread can happen on a continuum. Some viruses are highly contagious, such as measles, while other viruses are less so. At this time, it's unclear how easily or sustainable this virus is spreading between people, but we do know that it is spreading from person to person. This virus probably originated originally from an animal source, but now seems to be spreading, again, person to person. The person-to-person spread is evident by the fact that we can find no connections between travel associated to a travel-affected location or to someone who's been diagnosed with COVID-19. Contact with infected surfaces or objects is something that we've been talking about in terms of preventive measures. We want people to make sure that they clean and disinfect their environments and wash your hands, because the virus can be on your hands, but it has to get into the respiratory system to cause an infection. So washing your hands frequently and properly is very important, and also disinfecting the surfaces or objects that you commonly come in contact with, and keeping your hands away from your face, specifically your eyes, your nose, and your mouth. In terms of the symptoms associated with COVID-19, about 70 to 80% of all infections are mild to moderate symptoms. And I'm sure this will come up in questions and in comments by others, but everyone does not need a test for COVID-19. Just as we do when we get the flu, if individuals have mild symptoms, we are asking them to stay home until their symptoms have resolved. And CDC actually has just come out with guidance for individuals who are on home isolation to be released from that home isolation. But the symptoms associated with COVID-19 include fever, cough, and difficulty breathing. And at this time, the Centers for Disease Control and Prevention believes that symptoms may appear in as few as 2 days or in as many as 14 days after exposure. And this is based on what we have previously seen with MERS. We now know, and CDC has reported, that COVID-19 has actually now been reported in all 50 states. We do have an incomplete picture. We don't know everything about this new virus. We do know that it is now spreading from person to person. The case fatality rate has been identified as 3.4%, which is far greater than influenza, which has been reported at 0.1%. But it is less than MERS or SARS. So the lack of testing of everyone is, some people feel that's a problem, but just as, again, with influenza, everyone should not and cannot be tested because we don't have the capacity to do that. There is currently a lack of reagents associated with the testing, and we are working with CDC and making the request to get these reagents, and hopefully, particularly for those commercial labs as well as the hospital labs that now have the capability, that they will be able to obtain those supplies in the most near future. So I think just one other thing that I'd like to point out before I pass it on to Dr. McDonald, who is at greater risk for COVID-19, particularly greatest risk for having complications, and that would be individuals who are older, our older adults, and individuals with underlying medical conditions or compromised immune systems. And those chronic medical conditions are very similar to what we see with influenza, individuals with heart disease, diabetes, and lung disease. So with that, Dr. McDonald, I will invite you to the mic.
Thank you very much. I actually really wanted to stress 3 issues so I could let my colleagues talk about the preparations that they're having in their various respective health systems, and then to let you ask the questions that you want to ask. The first is I wanted to talk about the epidemiology in San Diego. I don't need to review what's going on across the world in the United States. I think you've been seeing that on the news quite a bit. But I do want to state that we do update our case counts in San Diego on our website, which is coronavirus-sd.com. Frankly, if you Google San Diego Epidemiology Program and click on that, you'll see a banner at the top, and then you can click on coronavirus, and you'll go to all the resources that we are updating daily in the county. We have updated links to CDC and CDPH websites, as well as the information I'm going to provide here. But in the last hour, we actually just updated it with the most recent information. And we've had a total of 80 cases that are confirmed with coronavirus in San Diego County. 67 of those individuals are San Diego County residents. 5 of them are individuals who are from the federal quarantine at Miramar, and 8 of them are non-county residents who were diagnosed here in San Diego. We've had no pediatric patients so far in San Diego. 63 patients were between the ages of 18 and 64, and the remainder were over the age of 65. We've had 11 patients who are hospitalized, and we've had no deaths in San Diego. Significantly, we've had 3 clusters of illnesses amongst the 67 San Diego County residents that I described. We've had a cluster of 10 cases associated with travel to Colorado, individuals who are related to each other by close contact. We have a cluster of 4 cases that involve some military and civilian cases that are in the same social group. Those cases were community transmitted, and we have a cluster of 4 cases that initiated with an individual who was on a cruise, and then 3 close contacts are associated with that. I describe those cases because that adds up to 18 of our 67 cases, and that's a significant number. And our epidemiology program is taking reports of each of these positive cases, investigating them rigorously, and attempting to diagnose close contacts and manage them to control potential outbreaks. But I would say that this description of what we've detected so far is not likely to be indicative of what's happening in the community. It shows who we're testing, but it doesn't necessarily show what's actually happening. And we have enough evidence to know that there is local transmission here in San Diego. While there are multiple viruses that are present in the community that can cause respiratory illness, essentially the take-home message is anyone in San Diego County who develops fever and cough could potentially be a SARS-CoV-2 infection, the virus that causes COVID-19. That is regardless of travel or exposure history. So what we want to do is just make that point, and then number 2, talk about how those individuals should be managed. Dr. Wooten described that over 80% of patients have mild illness and do not need to seek medical care. And indeed, really, we don't want them entering the medical system so that they aren't exposing healthcare workers and other vulnerable patients to COVID. So our number one message to the community has been, if you are sick with respiratory symptoms, you should stay home and be isolated. And you should be isolated until your symptoms resolve. And again, that's an important message for you to be emphasizing with your patients if they call in with concern and have mild symptoms. The first question that they're going to ask is, can I get tested? And Dr. Wooten also described that there are some significant issues with availability of testing both in San Diego and across the country. This is difficult because there has been some national messaging that indicates that any doctor can order a test and that tests are easily available. I think you know that's not true. We have a very limited amount of testing capability. We have some in the health department, we have some in our local hospital systems, and we have some in the commercial laboratory system. But the question is, who should be tested? Well, testing should be performed for individuals who have significant illness or patients who belong to populations prioritized for testing, and I'll give that description in just a moment. We don't want to be testing people with mild illness because we really want to direct those tests to assist us with management of patients who may be hospitalized and to help us detect special situations such as skilled nursing facilities or identify providers who may be amplifiers of the disease, such as healthcare workers or pre-hospital workers. The people who are in these categories are people with fever and cough who have evidence of lower respiratory disease without an alternative diagnosis, especially those who are hospitalized. Anybody who's in a senior living facility, including skilled nursing facilities and assisting living facilities, known contacts to COVID-19 patients, healthcare workers, persons who care for the elderly, or patients, individuals who are experiencing homelessness. Now, that was a quick rundown. I will tell you that there will be a health alert that comes out tomorrow that nicely describes the information that I just described. And I'll just apologize ahead of time. I was going to put some slides together for this to show you, but these guidance that I just gave you is literally being rapidly developed for dissemination. And that is a lead-in to my second point to those of you. You know that these guidelines have been changing very rapidly. Guidelines about testing, guidelines about protection, guidelines about who should be tested, really across the board. And again, what I would recommend to keep up with those guidelines is to go to the CDC's coronavirus website or to go to our website, which has links to those, to answer specific questions that you have, such as, what is the latest on PPE? What is the latest guidance that I should give to somebody who's traveling? What is the latest from my staff? And rather than taking a lot of time to answer those kinds of questions here, I would direct you to those resources because they change. And to get the most up-to-date answer, I would check there. Individuals who have mild illness and do not belong to a priority population do not need to be tested, but they do need to be told what to do. They need to be instructed to isolate at home for at least 72 hours beyond the time of their symptoms and to seek health care if they develop shortness of breath or other symptoms of severe disease. We don't want individuals calling public health to get tested, and you shouldn't be directing them there. We hope that commercial testing will be available soon and will be available through the normal resources that you get testing for every other cause. I would state that patients with respiratory illness probably have an alternative diagnosis at this point in time, and the most important one to diagnose is influenza. And so I would either presumptively treat for influenza for somebody that you're dealing with on a phone call, or if you have the ability to test them for that, you can test them and then treat them as indicated. Influenza is still in the community. We had nearly 600 cases reported last week and just under 20,000 cases reported so far this season. It is decreasing, but other viruses, unfortunately, are taking their place. Rhinovirus, enterovirus, and RSV are still causing a significant amount of illness in the community. Unfortunately, the symptoms are all very similar, and there are a lot of people who don't have COVID who are going to be instructed to stay at home, but unfortunately, without a rapid turnaround on a test, that is the proper advice to give to your patients. And as you know, we have been instituting across the county many non-pharmacologic interventions, asking people actually directing people to stay at home if they're in certain age categories. We are limiting the size of mass gatherings and social gatherings, and we're significantly curtailing, as you can see by looking out your door or by traveling in your car, the activity in the community in order to reduce the likelihood of person-to-person transmission. You might say, gosh, we're doing it early with only this number of cases. We're not doing this early. We're doing this exactly the time that we should be doing it, because if you've seen the curves of increasing cases in locations that didn't do these kinds of interventions, it's relatively quick. The cases double essentially every day, and it doesn't take much math to see that those numbers of severe cases would quickly overwhelm our medical system. The good news is we're doing preparations for that, and I'll let my colleagues do a little bit more detailing of that. But the other issue, I've talked about the epidemiology, I've talked about testing, and the last thing I wanted to talk about was infection control guidance. The CDC has been regularly updating infection prevention guidance for personal protective equipment, or PPE, and a summary of the current recommendations are that face masks are an acceptable alternative to respirators in the setting of shortages of respirators, and we are essentially entering a period where we may have significant difficulties with supply. And so you should be aware of that in your practice environment. The N95 respirators should be prioritized for procedures that are likely to generate a high concentration of aerosols. And that is such as intubation or a nebulizer or a CPR. But in most clinical circumstances, face masks with eye protection and gloves and distance is going to be the appropriate protection from your patients that may have this condition. Gowns and gloves are recommended for clinical care, but if gowns are in short supply, which they aren't currently, but you should husband them closely, they should be prioritized for procedures that are likely to generate aerosols. And so rather than spending a lot of time going into nitty-gritty detail, I would ask you to go to our website and look at the most recent guidance that CDC has produced, which is within the last 48 hours, to understand what you need to do in your practice environment. And I think I'll stop there and move it on to the other colleagues.
Thank you. And I think one thing that we will commit to, I'm going to keep track of some action steps. I want to ensure that all of you are even familiar with what the county website is. And so if we could keep a list of things that we will do afterwards, for sure, in follow-up, we will email out to everybody who registered a link to our website. Before I introduce and turn the table to our next guest, I want to just say something really quickly. There are many of you watching tonight, frankly, that probably are qualified to be up here, okay? But there was a decision made on who would participate. Obviously, Dr. Wooten, Eric, and I have a formal responsibility with you as representatives and health stewards of your local government. But we had a very interesting experience in San Diego County, and as a baseball fan, I will call it our spring training, in that over Super Bowl weekend, we got notice that San Diego, because of the presence of our military base, was chosen to be one of the locations where evacuees from Wuhan, China, would be brought. That was an unbelievable experience for us. Within literally 48 hours, under the leadership and tireless efforts that some of us even got to not watch the Super Bowl, to put a system in place in terms of appropriate coordination, communication. I don't know if you all realize the complexity of what was involved with the CDC and the Assistant Secretary of Preparedness and Response and the military and the local health officials and our local health systems. It was incredible. And it was a perfect opportunity in retrospect for, as stressful as it was for some of us, to prepare us for the major league experience that I believe we are facing now. And so 3 of the people that are joining us tonight were individuals who were key strategic and critical participants of that spring training experience. And so I'm not going to limit them to speaking about that by any means, but I do want to confess that part of their opportunity to be part of this event tonight was because each of them had a very, very critical role to play in that spring training, if you would, experience that we had together. And with that, I will turn it over and start with one of my medical school faculty members at UCSD. Never thought I'd see the day, John, that we'd be having this experience together, Dr. John Bradley.
Thank you very much. It's an honor to be here. Thank you very much, Wilma. It's an honor to be here representing Rady Children's Hospital and UCSD faculty in pediatrics. We are obviously the largest pediatric referral center in San Diego County, and it's been an absolute pleasure. Given the fact that we do have coronavirus, we need to work with public health officials, and it has been a pleasure working with Nick and Eric and Wilma. We contact them several times each day. They are always quick, informative, helpful, collaborative, and I think San Diego feels that there's no stone unturned. Every question is being answered, thoroughly investigated to support our medical efforts to make sure everyone is safe, diagnosed, isolated, and contained so that we minimize the impact of coronavirus in San Diego. I have just 4 points that I'd like to mention from the 40,000-foot view. And by the way, Nick was an excellent medical student. I remember him well. First is that we are ready for cases of coronavirus should they occur in San Diego. As Nick mentioned, we had our spring training. We put together our Ebola ward, which has turned into a special infectious disease unit with negative pressure. We are following CDC and county health department guidelines on personal protective equipment. So I got a chance to see the 5 admissions that came in from Miramar Air Station. All of them tested positive. So thank you. All of them, we tested them all. They were all negative. We've had no positive cases in San Diego, as Eric had mentioned. Thank you, Francesca.
In the pediatric population.
Of course, I'm a pediatrician. I only take care of children. So that's specifically for children. So we have had training, and when the CDC was here visiting hospitals, they had a chance to come by our hospital, and we're very pleased and happy with how we were following recommendations and guidelines. We have full support of our hospital administrators, medical staff, healthcare workers. We've trained everybody on proper approach to patients who are symptomatic. We believe we have a very safe place to take care of children. Everyone is on high alert for children with respiratory tract infections, and we're wearing our personal protective equipment when we interact with those kids. For kids that are asymptomatic, it's routine care at this point. So we are closely following San Diego County guidelines on our approach to management of patients. The other point I wanted to make specifically to pediatrics is that children in general do very well. Dr. Wooten mentioned that that most adults do reasonably well, 60 to 80%. Well, for children, and there are data that just came out from the Chinese CDC yesterday, suggests that 90 to 95% of children do very well and end up not needing extensive respiratory support. Even in the outbreak in Seattle, there was no child who was sick enough to actually need intubation. So we believe that that the impact on our healthcare system for children won't be as much as for adults, and actually our CEO of our hospital, Patrick Frias, has been in contact with other healthcare systems, and if there's extra capacity that we can help out with helping manage those young adults, we've already made that offer through public health. The other important piece of information is that we have research partners doing clinical research to improve diagnosis, treatment, all those sorts of things. And we've partnered with one group in San Diego to test for coronavirus on those NP swabs that are routinely obtained from children for multiplex PCR for regular respiratory infections, things that we've been doing for the past 2 years. And in sending those samples before we throw them away, with full permission of our Human Research Committee, unidentified samples that go to the research lab. We have over 400 NP swabs, and the county is aware of this, that have tested negative for coronavirus. So we do not believe that there's spread of coronavirus in the community in children with mild respiratory tract infection. That's a very key point. So we continue to work closely with our research partners and with our collaborators, but what we can say as of today, and Dr. McDonald made this point very clear, as of today, we don't believe that the children that you see out in grocery stores or in parks playing, that they have coronavirus. They're far more likely to have influenza, parainfluenza, rotavirus, metapneumovirus, all those other viruses that routinely infect children. So,
thank you, John, and obviously there'll be questions coming your way. I just want to echo one thing you made reference to, because I think it's yet another quick indication of the incredible nature of the collaboration and the deep appreciation that I have for your hospital leadership. This past Sunday morning, we had a historic meeting. Wilma, Eric, and I met with literally with other colleagues from the county, with every CEO of every major clinical healthcare facility in our region. And there are some amazing levels of collaboration being discussed. We are going to have another follow-up meeting this coming Sunday in all likelihood. And as John referenced, one of the things that's on the table, details to be sorted out and appropriately announced, is the possibility of Rady expanding the scope of even the age range of patients that they might be willing to serve. Just as an indication to you all of how serious and how collaboratively we are responding to this opportunity. Next is Dr. Torriani from UCSD, if you could please take it from there.
Yes, I am also delighted to be part of this group. As you can hear, my accent is Northern Italian, and so I am very touched by what is happening right now in Italy and what may be happening here and what we're trying to prevent to happen here. We do have excellent collaboration among healthcare systems and with public health, and that is absolutely essential so that we can contain and mitigate this infection. We have, at UCSD, had the experience of the Miramar evacuees. We were able to care for 2 patients who were COVID positive and many who tested negative. That was just a prelude to what is facing us, what we probably will face in the next few months. We have are working in coordination with the state, as the county, and other healthcare systems, including the UC system, with whom we share many, many protocols that are evolving over time, right? As the situation evolves, we're changing our way of approaching this. But let me just tell you about a couple ones. We have an incident command system that helps us coordinate this across the different hospitals that UC San Diego Healthcare is involved with. And we are screening. As of Sunday, we started screening all healthcare workers reporting to work for signs or symptoms of COVID. And so this is a very brief encounter, but at least it allows us to screen away individuals who might be sick and reporting to work. The second thing is we're also screening visitors to the healthcare system for symptoms and triaging them as appropriate. As all other hospitals in the region, we have stopped visitation that is not essential in accompanying other patients, and so we are not accepting any visitors. We are involved in research in different aspects, whether there is finding new ways of diagnosing this disease, but also in treatment protocols and for COVID patients. And so this will be a community effort that will require a lot of work and of involvement, but I have faith that this will work out. We will pull through this because you have the presence of such good partnership. That's all I wanted to say.
Thank you, Francesca, very, very much. I appreciate it. Eric?
Actually, can I make one point? Because something that you said was a point that I wanted to make sure was carried out in case we don't have time for questions. Is, you know, what can you do in terms of as a physician and a provider to approach this outbreak? And I think the first is that you need to take care of yourself so that you can take care of other people. And you should be avoiding any gatherings of individuals and follow that directive and social distance. And I do this every day. I take my temperature twice a day, and make sure that I don't have any symptoms. And you should be working as long as you are symptomatic. But if you get into the habit of doing it now, it becomes a regular habit. And you, even if you don't in your regular encounters with patients, have any concerning events, if you have signs and symptoms, you should immediately not be working with patients and sequester yourself at home. So I wanted to make that point because you said you're screening everybody when they come to work, and that's good, but you know, I'd do it before you go to work.
No, that's excellent. And I will also say again, the Medical Society folks really took a very proactive step, and it was in partnership with the county, where all physicians in San Diego got a message from the Medical Society reminding them of what just was said by both Francesca and Eric. And then that template and that concept was even used for messaging that within the last 48 hours, we at the county, through EMS, the department that I supervise, we blasted that message out to every pre-hospital worker that we monitor and license throughout our region. So obviously, we all have a role to play. Every one of us here tonight is part of a team. And I just quickly want to say that for all of us at the county, we have an incredible team working together. I personally have an EMS medical director named Dr. Christy Koenig, who, because of a previous academic commitment tonight, could not join us. But I asked Chief Andy Parr, which with a vision that we have of the continuum from the pre-hospital experience to the healthcare experience, I consider Chief Parr to be a clinician. And so he's here tonight, and want him to give a little bit of an overview of some of the things that we experienced and did at Miramar and some of the ongoing things that we are doing specifically in our pre-hospital environment. Chief Parr?
Well, thank you very much. Emergency managers deal with all kinds of emergencies, and San Diego County is one to have many natural disasters. We all expect and should be prepared for an earthquake. We had an earthquake over 5 in Northern California today on top of everything else. Another one in around the Salt Lake City area. So our natural disaster possibilities remain high. We have emergencies in our environment, according about wildland fires or hazardous material spills, and the emergencies surrounding mass casualty accidents, a train crash, or a contagious disease are something that the county and all of its emergency responders train, exercise, and work with on a regular basis. I'm very, very proud to be part of the county team as we move forward with this is not an exercise, this is the real thing, and we're planning to handle it as best we can. The complex method of communications, of the establishment of an organization, of supply, materiel, and those things that are associated with a response to an outbreak like this or a event like this is massive. It is a very heavy lift for our emergency responders, not just the 911 call takers and the paramedics responding to all kinds of medical emergencies in the field, but the entire machine of our emergency services is in full force. The 18 cities, the county of San Diego, all of the special districts, including fire districts and school districts, are all an integral part, and everybody has a role to play, and they're just a few feet away here in our Emergency Operations Center, where those representatives from all those different agencies are meeting together and planning, plotting, and responding to the emergency. There is access ready and able to be made for storage access to emergency storage on the local level, on the state level, and the federal level for emergency supplies, including protective equipment for our responders and for our physicians as necessary. We're working very closely with our healthcare sector to provide whatever supplies they need in the event that they're running low. There's not an unlimited supply, but currently supplies are available, and we are filling orders from our healthcare sector. We have excellent emergency managers here in San Diego County. This is the big leagues, as Dr. Nick mentioned earlier. This is an opportunity for emergency managers to come and train and really exercise their skills. Inside San Diego County, the Department of the Office of Emergency Services is a small but very important element of our public safety group, along with the sheriff and the county fire department, and they're fully activated, including the emergency manager is our, if you will, deputy or incident commander of this, so he's actively engaged at a very high level. Our county government is completely engaged in the program, and our supervisors and other elected officials are frequent visitors and interactive with our calls that are going on. The Public Health Department has a preparedness and response branch that basically plans for emergencies just like that. They're fully engaged and have stood up to level 1, the Medical Operations Center, which is a well-oiled machine to be able to dispense materials. But the cooperation between the cities and the county, as I've said, as Dr. Nick has mentioned, has been excellent. We're seeing that in living color. We're operating around the clock with the building active for 12 hours a day, but on-call people at night, and that's 7 days a week. And I'm very, very proud to be part of this, and I'm looking forward to getting past this, but just like we all are. But I would say that what is exciting about it from the emergency management perspective is that this is an opportunity to really serve our community. Right. This is something that we have trained for. Every firefighter, every police officer, every EMT, they've trained for this. This is, in their training, this is a very key and important point, and they get to see this in our lifetime. I think it's a very good thing, and we hope it never happens again.
Thank you. Thank you, Dr. Parr. Appreciate having you here tonight, and it really is a collective effort. All right, folks, we are going to transition now to answering questions, and I will quickly acknowledge there are many of them. And so we will do our very best to be succinct. I am going to be triaging questions as they come, and we will kind of partition them accordingly, and there may be questions that require more than one person respond. So here goes, and I'm very impressed with the sophistication of some of the things. I should not be impressed nor surprised, but some of you are extremely insightful with the things that you are asking. I'm going to ask two initial questions, and I will answer them, and they are as follows. There have been over 2,000 healthcare workers in Italy who tested positive for COVID-19 and are afraid to go home and spread the virus to their families. Will San Diego County have a place for healthcare professionals to go on their day off and prevent spread to the community? Part B of that is, will San Diego County offer safe places for healthcare workers to self-quarantine? I don't know if any of you have the time to watch our media reports, but this is something that we are very much already on top of, but I'm going to transparently acknowledge right here that we have not, in my opinion, been thoughtful to the point of taking this aspect into consideration. We've been doing a lot of planning with regard to the unsheltered homeless, to the homeless who are in shelters who turn into PUIs or confirmed cases, to individuals who are discharged potentially in the future from hospitals that may not have a place to go to, or who are clinically enough stable that don't need to be into the hospital, but have many members of family at home that they are living with that we need to, quote unquote, protect them from, making sure that we ensure our inpatient capacity is being used appropriately. And then another issue that's already come up and is very much on our radar screen is the issue of folks going from skilled nursing facilities to hospitals, and then upon their evaluation, there's been some potential limitations of them going back to that same facility and so forth. Supervisor Fletcher has been a passionate advocate for this, as has our entire board. And so what I will acknowledge is that our focus in terms of extra housing has really been primarily on this high-risk subgroup of people that I quickly described. But this suggestion by a couple of you is a fantastic one, and it is now on my official list to follow up on. And who knows, in light of the impact of tourism and travel, that I'm not making any promises, folks, but the possibility that there may be hotel facilities or things like that that could be used for this purpose is something that I will commit to the county exploring.
Can I just throw in a quick thing? That really leads to a point that I'd like to make. And you have a patient who has mild illness, isn't part of the priority testing group, doesn't need to be tested, or in fact has been tested but is yet able to go home and isn't able to go into one of the environments that you're describing, say a homeless person on a work furlough program, person who lives in a dormitory setting, person who is in a drug treatment facility and can't be isolated. These are people who are eligible for temporary housing. This is a for-provider number only. but the staff that you have should call the following number. It's 858-715-2350. That number is staffed between 7 a.m. and 8 p.m., and this is the connection to place individuals into the housing that Dr. Nick just described. And so if you have one of those patients, that is the mechanism to get them to where they need to go.
Thank you, Eric. And again, to my team, that is the additional official piece of information that I would like to go out to all participants, the clear summary of what the indicated individuals are for, and that specific number, obviously, so that you can have it at your fingertips. Francesca, the next question is coming to you, and that is, coronavirus has been around for years. Is there no partial or residual immunity?
No, there's a lot of coronavirus, and this coronavirus is a novel coronavirus, so there is no immunity provided by previous encounters because this family of coronavirus is very large, right? So it's a new virus, there's no immunity, and that is why it is people are getting infected and basically cannot respond to it in a way that means that they're not getting infected.
Thank you. John, anything you want to add from that, from a pediatric perspective?
No.
Okay. Thank you. The next question is kind of a two-part question, Dr. Wooten. Part of it's going to come to you, and I will answer part of it as well. The question is, does the county have in place plans for shelter-in-place directives, and under what conditions will that be? There is a second part of that question that I'll quickly address. Actually, Dr. Wooten, I'll pause, and could you address that, and then I'll come back to the second part of the question.
We are utilizing all of the tools in our toolbox. Right now, actually today we issued an order to decrease the size of individuals that gather together in one place from 50 to 10. And it could go down to we will not recommend any gatherings in place. So, and actually I've talked with my colleagues in Southern California, and that's something that we've landed on. The shelter in place, the term is, the term itself, some of our colleagues don't like the term, but it really doesn't matter what term you use, it's what actions you take. So going down to gatherings of no more, or actually prohibiting gatherings of 10 individuals or more, I think is a step in the right direction, and we may ultimately inform the public that we recommend no gatherings. And actually, with that order, we said strongly urge people, if the meetings are not essential, we encourage them not to have them at all. So this is an example of this event here tonight. This was originally planned to be an open forum where we were going to gather together, and when we issued the order, we immediately changed this to a virtual meeting. And so you can be creative and meet and not have to be face-to-face.
Thank you, Dr. Wooten. And folks, this is a key issue, and I'm just going to say it ever so tightly. The needle that needs to be threaded by Dr. Wooten and those of us at this policy level in terms of making broad decisions in hopes of protecting the public health and protecting the health system's capacity to respond, they also have to be made in the context of realizing the substantive impacts that are being felt on people in terms of economics, child care, the capacity to gather in faith-based settings, and the list is long. I just want you all to know that those decisions are made with tremendous deliberation by those of us at the county, with input internationally, nationally, and regionally in California. And as your stewards, I consider it to be one of the biggest responsibilities that we have. Part B of the question is, many MDs feel pressure to continue elective surgeries that hospitals and surgery centers are not yet canceling. Suspect because part of integrated groups which function as employers. Should we be pushing a public health order to ban? Folks, as a matter of fact, that has already occurred. And the third resource that I would like to promise that we will send tonight is the link to the latest guidance and public health orders that came out today from Dr. Wooten. Frankly, this also is a substantial decision that we made, and I can tell you we made in harmony and unison and collaboration with the top CEO-level executive partners of our entire clinical care delivery system. Now, you could say that there are independent surgery centers and so forth that we did not consult, but based on with what we're facing and based on positioning ourselves to be able to prepare for what we expect is coming, those decisions have already been made, and we will send out those orders. The next question, it would be helpful to have more specific guidelines about protecting office staff seeing sick patients versus acute non-respiratory patients, surgical masks, eye protection, for which staff, front desk, MAs, lab techs, given PPE shortage ratio. Eric, you kind of touched on this, but could you repeat some of the highlights of what you've already said, please?
Well, I think really I would refer to the CDC's guidance. It's on our website, and for that type of very specific question, I would go there and base your individual practice decisions based on your access to supply and projected supply over time. I think to follow on your comment about the surgical centers and individuals who have reduced practice load because of the decisions that are being made, I would be approaching the medical systems, the one that you feel that you have a closest link with, or perhaps one that's represented here. Those are systems that are going to need your medical talents. And I think that if you access them as a volunteer, you will be needed. And so I would direct you to those organizations.
Yeah, and Eric, that brings up, I'll come to you, Francesca, in a second, and that brings up, I think, another key opportunity with our medical society leadership, and I think some further unpacking that will need to occur. Folks, there are part of the clinician workforce that, based on decisions that have to be made, that may not be as busy as the rest of us. As a result of what we are likely going to face, there are going to be some of us who are completely, I don't want to use the word overwhelmed, but that are going to be completely in high demand. This is the kind of innovative opportunity that I think we need to start thinking about now, of how do we coordinate that kind of perhaps unconventional and maybe even previously unheard of collaboration, which I have read and I know has already been experienced in other parts of the world, where certain specialists literally got involved with providing care to individuals that they maybe were only minimally, if not at all, formally trained to deal with. So be thinking about that. And Francesca.
The comment I wanted to make is that there's two lines of first protection, right? But the protection that is most important is if we have somebody who has acute respiratory symptoms, the first line is mask that individual, right? That's your first protection. And so to all of those people who are in the frontline screening, that is our first thing to go to and keep the distance, right? If you keep those 2 rows in an airplane or those 6 feet, you don't need to have a mask, basically. It's only if you engage nearer to those 2 feet that you need to have that protection. And especially in this time when even surgical masks are getting short, this is really imperative. Protect, mask the patient, and then protect yourself if you engage at less than 6 feet.
Thank you, Francesca. And I want to, again, this is such an important point, folks, in terms of our regional stewardship of this potentially precious resources. And it's totally understandable. But early on, when we were dealing with some of the evacuees from Wuhan and so forth, and totally understandably, there was some utilization of PPE in different environments that perhaps was not ideally indicated. And so I think in the long run, all of us heeding this message is absolutely critical. John, the next question is coming to you, and it's got a few components to it. Can you explain, and I don't know that you can, can you explain cytokine storm, why Motrin is bad for the virus, and the possibility of chloroquine? Because as a pediatrician who's seeing patients, I act like I am a carrier, and my patients are too. So cytokine storm, Motrin, and chloroquine.
Okay. The cytokine storm is something that we've seen with other viruses, some strains of influenza, like the avian flu, where the lungs just would have massive capillary leak from the inflammation. And in a small percentage, but an absolutely reproducible percentage of adults and kids, this kind of ARDS that you get with cytokine storm seems to be a character of this virus. So it's not quite the old SARS, but it's close. And right now, managing most of those patients with oxygen or positive pressure without the need for intubation is what we're seeing. There aren't that many treatments for cytokine storm, and in some of the early data that are coming out using steroids for horrible pneumonia, it looks like the outcomes are not better. And as we've seen with influenza, and it's published, if you use steroids, the outcomes are worse for influenza. So we have a lot to learn about the cytokine storm. The ibuprofen, and I know the World Health Organization has just come out with information cautioning on the use of ibuprofen, but it's anti-inflammatory, and the body's response to an infection, both the appropriate response and potentially an over-response with too many cytokines, is blocked by ibuprofen. We were considering this during the toxic shock, streptococcal toxic shock era, when we had some information that linked ibuprofen use with more serious toxic shock disease. And in reviewing the data, it wasn't clear whether it was the sicker patients who ended up getting more ibuprofen simply because they were sicker, or whether ibuprofen inhibited the host's immune response to allow the pathogen to grow more and more toxin to be produced. So the story's not out on ibuprofen, but if you can use acetaminophen, Tylenol, that's the first drug you should go to. But I wouldn't discount ibuprofen completely yet until we have more data. And the third question was about chloroquine. And there are probably 20 different drugs that are on listservs going around to all of the therapeutics researchers in the country and the world. I know the EU is very involved with this. And there are direct antiviral effects, there are anti-receptors, anti-inflammation, and so chloroquine is one of about 20 different drugs that are being teed up for clinical trials. So yes, it might work, but right now I'm looking at the FDA-approved research trials if I need to use an investigational drug to treat a very sick child. And the other thing is this pediatrician was worried that he might be spreading it even though he's asymptomatic. And I think that's a very critical question, because there's probably a difference between early PCR positivity, which we see with influenza, before the actual infectious dose of virus increases to the point where there's contagiousness. And the last time I looked on the CDC website yesterday is that they're still sticking with the fact that you are much more likely to be contagious when you begin to develop symptoms. So we're not telling people who are asymptomatic that you're contagious, and that's causing a fair amount of paranoia that people are worried that they don't have any symptoms and they could be spreading the virus. So again, we turn to public health with advice on the likely contagiousness. And so for this questioner, if you're not symptomatic, you don't have to worry, as of today, that you're going to infect any of your patients or your family.
Thank you, John. Chief Parr, the next question is for you. What protocols are in place to ensure that ambulances in destination to both patients and then to hospitals are potentially transporting them safely?
There is specific protocols in place for infectious disease protocols for everyday use, but in this particular case, there's specific guidance from Dr. Christy Koenig, our EMS medical director, in consult with the CDPH to assure that patients that are being seen are the paramedics or EMTs that are responding are in appropriate PPE and transporting the patient ahead to the hospital. But let's be clear, when EMS is activated, they call 911. In each one of our civilian 911 centers, they are asked a series of questions that provide key information to the EMTs before they arrive. We've added additional questions to those normal questions that talk about symptoms, that talk about travel history, talk about exposure to other things. So if there's a case where the patient says, gosh, you know what, I did travel to Europe or something like that, that would be indicated to the paramedics via their communication system, and they would arrive, don PPE before they even make patient contact. Then after they make patient contact, they would, of course, notify the hospital that they're coming. They would tell the hospital that's receiving them that they're bringing in such a patient, so the nursing staff and the physicians at that facility would also know that this patient had indicated they were perhaps exposed. So I think the system is in place. We just hope the patients who call ahead say the truth, and that's an important part of this whole EMS mission.
And that is something that we will continue with our public messaging as well. Thank you. The next question, comment about liability with Cal OSHA still stating airborne precautions and UCSD RNs and others demanding airborne precautions. I think we've talked about this, but in terms of the specific Cal OSHA liability, I believe that with the governor of California's emergency declaration that any of those liabilities are now suspended. And I look to my colleagues nodding head that I hopefully said something accurate.
And that's a good one for us also to pass on, is to specifically pass the governor's orders on this so that they can actually see that in writing from the governor's declaration.
Thank you. Francesca, related to this, the next question to you. Why are UCSD employees not allowed to wear N95 masks currently?
So that is incorrect. The first thing is that there is right now no evidence that, or there's a lot of evidence that this disease, that this infection is spread through droplets and contact with fomites, with infected fomites. And so the main mechanism of transmission is that 6 feet rule and not airborne. And therefore, airborne protection is reserved for a setting where you have aerosolized procedures. And that is when we need to intubate a patient, when we're going to do a bronchoscopy, when a respiratory technician is giving life-saving treatment to a patient who's COVID positive. In those situations, clearly, we want personnel to be wearing N95s on top of, or first N95s and then their mask with the screen to protect them from droplets. That is really the essential message that we have to give here, is we want to protect our healthcare force, and we want to protect them in a way that they are not only protected, but they are also comfortable with the donning and specifically with the doffing of this personal protective equipment. And that is why we have defined these areas where we use airborne, and we have defined every single encounter with the proper PPE based on scientific data.
Thank you, Francesca. Very interesting and good question, and I needed help from my colleagues to have the answer to this one. Are there resources for isolated seniors, a way to get them food donations and deliveries as needed? What I can say at this point publicly and transparently is this is clearly a need now that we have identified, and urgently a collaboration is in the works as we speak that will be engaging a volunteer corps and connecting them with feeding and delivery services. The logistics of all of that are being finalized so that when it is launched and operationalized, it is done the right way. And the website that we are going to be circulating to you all after this is the site where that information will be available. And I would suspect, Dr. Wooten, that in our future press conferences will be something that we will be giving updates on as well. Next question. Is there a plan to close the U.S.-Mexican border? Many people commute to work and cross the border for medical care here in the U.S. How will this impact the community hospitals that rely on these patients? And folks, monumental question. There's county workforce, there's healthcare workforce, there's essential businesses and entity workforce. The relationship that we have with Baja California and across our border is very critical. From Dr. Wooten or Dr. McDonald, I am not aware. Do you have any follow-up in terms of discussions on national border closings with Mexico?
So from the White House COVID-19 task force this morning, it was stated that the U.S.-Mexico border will not close. However, President Trump alluded to possible limit or prohibition of asylum seekers or near future during the question segment. This is just
from today's press conference.
So usually it really takes an act of Congress to close borders. So
yeah, but I have to say, and it is an excellent question that's very much, again, from a broad healthcare workforce, folks. It's not just about us as clinicians. A lot of the people that support us and work so intimately with us enable us to do what we do. So, Eric, more to add to that?
Just a couple things. This was a specific question that was of concern of our local hospital systems, and it has been brought to our political leadership to then bring to the governor's office, so that that feedback about the impact of our on a binational community has been given through the political process. So I just wanted to make that point. And then number two, what about the epidemiology in Baja California? There have been 2 cases of COVID-19 that have been diagnosed and recognized in Baja California to date. Those were actually within the last 48 hours. Those 2 individuals live in Mexicali and, in fact, had a travel history to Washington State. So, the Mexican Health Ministry has a system set up to be able to screen and to test. It is centralized. It had been centralized until about 3 days ago, but now they have the capacity to test in the Baja California, and so they are increasing their testing. They have the same concerns and limitations that we do with reagents, and they are directing their testing in a specific way, and they picked this one up from a travel history. So I think that's important to note.
Thank you. There are, as would be expected, a tremendous number of questions here related to testing. And rather than reading them all, I'm going to make a few comments, and then I will allow Wilma and Eric to edit, amplify, and reinforce what I'm about to say. Folks, as I said on the news conference pretty emphatically a couple hours ago, as we transition, and this is so important for you all to understand, as we, I say, begin to transition from containment to mitigation, the strategy of testing changes. You know, it's almost ironic, even though it was just barely over a week ago, to think that the 3 of us held a whole press conference just based on the first non-evacuee positive confirmed COVID case that we had in the county. Folks, we are very much moving now from looking at this as an individual challenge to a population challenge. And we have to begin, all of us, looking at the transition that has to occur of testing that will be required for the people who need it the most. Yes, we are developing some strategies and doing some fascinating pilots in terms of, for example, drive-in, drive-through testing sites. Yes, some health systems are doing some of that on their own. Yes, we have people on our staffs at the county that are trying to get their arms around that and coordinate that and have a regional strategy rather than, silos of uncoordinated efforts that are going on. But it is critical that testing, and I said this before the news cameras this afternoon, not everybody that wants a test is going to get a test. We are past that point now. We do not have the supply for that to occur. And that is such an important consideration. But yes, there are certain high-risk populations. Yes, there are certain situations. And yes, for the tests that we are still doing through our public health laboratory, we are following CDC guidance, which is constantly evolving. If the commercial access to testing grows at the pace that we hope and expect that it will, you will not need authorization from Dr. McDonald and his staff to obtain those tests. What we are asking for, and as part of Dr. Wooten's directives, is that all test results, by the way, not just the positives, We also need the denominator so that we've got the intel to be able to do the modeling that will help inform further decisions that we have to make into the future. Those things have already been put into the directives. So for all of the questions that are here, and I'm not ignoring them, I'm still going to review and go through each one to make sure that there are aspects of it that we have not addressed. Every one of us as clinicians needs to understand that transition period that we are currently in. And Dr. McDonald, if you could edit me or correct me, and then Dr. Wooten the same, please.
Well, I said that in my introductory comments, that it is, and I'm just acknowledging it. It's extremely frustrating and maddening, frankly, that we don't have a testing capability that is already fielded for us to support clinical decision making. But the fact is we don't. And until we do, we need to be judicious in how we use it. I think that, again, the commercial laboratories and the partnerships that are occurring in the background to increase the testing capabilities will be communicated as they become available. But at the present time, the important issue is to not concentrate on the test, but to concentrate on symptoms.
Right.
And that is, if a patient with symptoms, even if you've got the test, is going to take some time for the result to come back. And they must be self-isolating during that period. And that period, we hope, would be very short as time goes by, but at present, with mild symptoms, you won't have a test result. And even when we get test results through the commercial system, it may take days to come back. So it's very, very important, and it's understandable that both patients and you are focused on testing to get away from that and to focus on symptoms and the action that's required, which is to isolate the patient.
Dr. Wooten, anything to add?
Well, two things. CDC actually just came out with the discontinuation of home isolation for persons with COVID-19. And before that, and there are two categories. The first category is for those individuals where you are not getting tests because they're home isolation, so they've not been diagnosed, but they're being home isolated because we are presuming they have COVID-19. And then the other is if someone has been diagnosed with COVID-19, then their return or to be discontinued from home isolation will be contingent on two successive negative tests, at least 24 hours, but it only needs to be the nasopharyngeal now, not the naso and the oropharyngeal. If someone has been told to be on home isolation, then, and Dr. McDonald has talked about this in his previous presentation, but at least 3 days or 72 hours have passed since the resolution of your fever without the use of antipyretics.
And we will provide a link to that specific guidance about how to discontinue, precautions.
Yes, and then at least 7 days have passed. The other is at least 7 days have passed since the first symptoms appeared. And the second thing that I was going to say is just what Dr. McDonald stated. Might be useful to do a KHAN, but also a daily message for your clients, your patients, so that they understand about testing as well. So both the provider community and your patient population get that information. And we produce daily messages every day, and this has already been slated to be one developed on testing.
Thank you.
Dr. Bradley.
So we're in an emergency situation, and this isolation, particularly of healthcare workers, so that we don't have the potential to spread it, is a huge issue. And as a pediatrician, healthcare workers have children and grandchildren, and they are still having all these respiratory viruses. And because we don't know for sure that these respiratory viruses are COVID, the normal way you interact with your kids, by picking them up, hugging them, kissing them, knowing that you're going to get an infection. And in the past, we sort of looked the other way as people came in with mild colds. We can't do that anymore. So So this social distancing, which is with strangers, we are now suggesting to our medical staff that you distance yourself from your children who have infections, because if you get an infection, we won't let you work. Mm-hmm. And we've never done that before. So it's an emergency. They're really trying times. And so you may be able to hug your child, but to kiss your child and risk getting an infection, we're now discouraging. So
when they are sick.
When they're sick, absolutely. And there are a lot of them who are sick in San Diego.
No, and that is a key thing, and I quickly want to contextualize that because I put that out again in the general public today. You know, folks, a lot of what we're doing, a lot of the NPIs and the strategic things that Dr. Wooten is doing are obviously to protect the health and well-being of our community, right? And I feel like we are much more proactive than many other parts of the world and maybe our own country in doing what we are doing. But I want to emphasize again, that is also about protecting the capacity of our healthcare delivery system. And it's not just about the ventilators and the ICU rooms. As John just said, and I again want to reinforce, you cannot take care of patients with ventilators that don't have nurses with them. And so this is a monumental, not only challenge, but I think fair to say unprecedented level of engagement. And that's why I say we are making and living history, because these kinds of deliberate actions of literally taking into consideration of how we interact with those who we love the most, our children, in the context of them being symptomatic, is just a fascinating and new consideration. The next question, is there, Francesca, forgive me.
I had one comment that relates to healthcare workers getting sick. The WHO report on the Chinese, the first month and a half of infections that goes until nearly the end of February, determined that the infections occurring in healthcare workers were acquired in the household context, not in the healthcare context. And that is by contact tracing, but also studies of whole family members. And so when in some ways, that is the dilemma, right? We go home to our families and we want to interact with our families because that is what we need to do, to distress, to do. But at the same time, that is where the infections are, that's where the transmissions will be occurring as long as we follow proper PPE instructions, right? So we are faced with two challenges, right? It's the challenge at home in how we relate to our loved ones and our family, and that social distancing that is really important. And then the challenge that we face at work, because we have to be careful with our PPE, and we really have to kind of mesh both to survive during these next 2-3 months.
Thank you, Francesca. John, just a quick question. I think we've said it, but I'll ask it again. If you can have asymptomatic people spreading the virus, why is there not required testing for all medical personnel? One more time.
There are data to show you can be PCR positive just before you get symptoms, but the numbers of infectious virus particles is extremely low, and you are unlikely to spread the infection. Now, we know that inoculum is a large part of who is going to actually contract the disease after you're exposed. And one of the things that we haven't addressed very much with spread is that if there's intimate contact, so if someone is kissing a spouse, for instance, then even a few viruses can potentially spread. But in the healthcare environment, we're not kissing patients. We're maintaining our distance. So your likelihood of picking it up from a patient, or your likelihood of giving it to a patient, if you're asymptomatic, is essentially zero, and that's following CDC guidance. And as we learn more about infectivity with just PCR positivity prior to symptoms, we may end up changing that. But as of right now, we do not believe that asymptomatic patients can transmit it to healthcare workers, or that asymptomatic healthcare workers can transmit it to patients.
Thank you, John. With 15 minutes left, we are going to transition to the giddy-up tone of answering questions. Eric, if a physician has a sore throat but no cough, fever, or shortness of breath, should they go to work?
No.
Any clear guidelines for outpatient specialty clinics? I will handle this. Should we be only telemedicine or only be seeing low-risk urgent patients? Folks, that's a complicated question, but I will say this. Now is the time, tomorrow is the time to start planning, if you haven't already, for those of you who are in the position of transitioning, if not a portion, perhaps a majority, or your entire practice on the telemedicine platform. There are new guidelines, I know, at the federal level. We don't have time to unpack in terms of Medicare guidance and so forth, but I believe, hopefully without, overly energizing any of you, now is the time to plan for the transition to that platform. Eric.
Just a quickie, again, many of those in the audience are small business owners. And it's important to know that there is guidance about the impact on small businesses that is coming from both the federal and the state level. And we need to make a note to make sure that we send those links about how individuals can seek relief because of the impact on their small business to those who are in the audience.
And the medical society, folks, I feel like I'm plugging the medical society tonight. This is one of the key resources, and there is a lot of messaging that's going out in communication related to this. With the directives that we gave a couple days ago, people are worried about bartenders. Folks, some of the things that we're talking about here are going to have economic implications on us as clinicians as well.
And as employers, I mean, I know you care about your employees, and so making sure that they have access to the sick leave that they need to be able to stay at home when they're ill. They don't need a doctor's note anymore, and even from you. But it's important to know if you're getting requests for doctor's notes, those are not legally required at this point. That specific need has been relieved by our governor. So again,
and by our health officer's order.
And by our health officer's order, that's correct. So again, the small administrative details that we don't have time to go in for, but again, I would point to the Medical Society as a resource.
Thank you. Is there a place where people with no insurance can go for a COVID test? I think we've dealt with a COVID issue, folks. I will say we have the strongest safety net of federally qualified health centers in the country. If there are still individuals who do not have access to care, there's 211. We have foot teams that are going to be going out to the community like we did with hepatitis A and doing outreach to the homeless. To me, if I was uninsured, I would love to live in San Diego County. How many people were evacuated, Eric, from Wuhan to San Diego?
It was 238 individuals were evacuated from Wuhan, and actually 498 were evacuated in the current evolution from the cruise ship that was entered in Oakland.
And it's fascinating because some of the folks that have come from the cruise ship, many of their states, including my favorite, was the couple from Iowa that got a jet ride back by their governor, but many states have coordinated transportations, and they have gone back to their states. I think by the end of today, we'll be at about 200 California residents.
Well, actually, there's going to be about 199 individuals who are left there under the current federal quarantine. 136 of them are California residents, and 2 of them are San Diego residents, and the county has been supporting them.
Okay. Francesca, how long is a patient contagious after symptoms resolve?
We do not know yet because it depends how the disease is affecting, right? We know that for some patients with pneumonia, we were able to detect shedding, and we don't know if this is a live virus or simply virus that is there. We were able to detect shedding for more than 3 weeks, and it's all dependent on the degree of immunosuppression and on conditions. So I would say for the normal run-of-the-mill person who does not require, a lot of medical care, we now are considering, basically are saying, until symptoms resolve, right? And what we did with a couple of patients we had from the Wuhan evacuees, we kept them in isolation until the cough resolved. Now we're saying that once the fever resolves and they have recovering symptoms from cough, then they need 3 more days, and then they can come out of isolation.
Thank you, Francesca. John, do we know how long it lives in the air?
That's a great question, and I'm going to separate that into 2 categories. One is, if it's droplet infection, from what we know from influenza, the droplets tend to fall. So we are not isolating for aerosolization because large droplets will fall. So how long is it in the air? So if you were to look in the air a few hours after someone had sneezed, you should find nothing. However, there's just publication that we referenced in the New England Journal where you can create a aerosol chamber, and if you create an aerosol chamber and you sample it, you can prove that virus is still in aerosol form for several hours. So again, that emphasizes that if you're doing aerosolization procedures, you need to have it in the proper room with proper protective equipment.
Thank you.
And then that the air exchanges during that time, right, will be sufficient to eliminate the virus particles. So that's why we have the rule of 1 hour after use in aerosolization procedures.
Thank you. This is something I have not previously thought about and might go on our list as well, Carrie. I don't know if there are logistics associated with this. And I'm going to say your name because it's such a thoughtful question from Brooke. Is there a place we can donate from our private clinic any extra gloves, viral swab kits that can be used for COVID-19 testing? We have not set that kind of a resource up yet, but I would think, Dr. Wooten, it'd be something that, depending on how things go, that we would be open to, correct?
Absolutely. As you may recall, during the fires, we set up the possibility for people to make donations. So that's coordinated through the EOC and Jeff Toney, the director of the EOC, can coordinate that effort.
So why don't we put that on the follow-up list, please, from us in terms of we'll figure out what the appropriate mechanism is to do that. Another issue we have not talked about, but whoever of you would like to take it, I am currently reusing the N95 as I don't have enough. The office puts them on and off with clean gloves next time. We currently have enough to change them out once a week. We are bagging and dating them, and they may need to be reused until we run out of our supplies. Anybody want to make a comment quickly? I know there's guidance about this, Eric, right? In terms of the reusing the N95s?
I mean, I think if you have surgical masks and shields, face shields, that is better, right? If you are, I mean, I think it all depends what you have available. If you have a system that allows you to reuse your N95 or a mask that basically allows you to not contaminate, then that is probably a good option.
Mm-hmm.
But the contamination is for me a big concern.
Yes.
Okay. This is fascinating. I personally have not heard about this before, so I'm not going to even be qualified in answering it. Is there a link between ACEs and ARBs and morbidity?
You know, I've seen that question before.
Yeah.
Francesca, any quickly?
I had a discussion with my husband, who's a cardiologist, about this, and we had a very lively discussion in infectious diseases. So there is some thought that ACE inhibitors may basically interfere with interfere in a bad way with the same attachment of the viral particles, and therefore that they should not be used. The European Society of Cardiology actually looked at this, and they do not recommend stopping or switching off of ACEs or ARBs, because they feel that the scientific evidence is not there. That's all I can tell you.
Perfect. Okay. We are almost at our time, and I am going to read one last question, and I will, because it's an important one, and I thought of an analogy that I've shared with my fellow executives today. Dr. Wooten, Dr. McDonald can respond as well, and then we have one request of you all, and we will wrap it up here in just a few moments. The question is, how many cases would you estimate are currently present in San Diego? Testing is so limited as to be meaningless. You may even see this in the Union Tribune tomorrow, because I had this discussion with a reporter. I'm not a genius. The analogy I used is that what we are seeing with our confirmed cases is the tip of the iceberg. But I think the reality that we are facing is that iceberg under the surface of the water is currently growing. The intention of our non-pharmaceutical interventions and all of the strategic, forward-acting, and meaningful interventions that we in public health, by some people's standards, are imposing, by our lens, are lovingly encouraging and at times directing out of love for our community and our health system and all the things that we have talked about. Those are all intended to keep that iceberg as small as possible. I hope you realize that the consequence of that is that the epidemiological curve is likely to be extended. That could prolong some of the hardship that people are going to be facing. That's going to prolong the economic challenges. That's going to prolong the academic and educational impacts and the host of things that people will be dealing with. But our hopes in doing this, with the very strong likelihood that we may even be doing more, is to keep that curve flat enough to protect the delta between our health system's capacity and the number of critically ill individuals that we are dealing with that need the appropriate level of care at the right place and the right time. And I'll leave it at that. I don't know if Eric or Dr. Wooten have anything else to say specifically related to the number of cases.
Well, there is modeling from the MITRE Corporation looking at hospitalization, ICU cases, and deaths. And based on what's occurring in your community, you can calculate the true number of cases. So I'll just stop there. And we are trying to...
And we are actually working with some of our colleagues at UCSD and folks, you know, not that you're all lab directors, but that's part of the reason that in our directives, we are needing not just positive results that are being done at the various commercial and now growing health system sites and genomic sites and all the things that are coming online. We need the numerator and the denominator in order to do that testing. For those of you who are still remaining on the line, as I make some closing comments, I have a specific favor to ask of you, two of them as a matter of fact. At this moment, and our people are on standby waiting to capture this, if you thought that this was at least somewhat productive, we would like to know whether or not this is something that potentially you'd be interested in doing again. And so if you could simply, at this very moment, even if you haven't engaged in that feature, enter a yes or a no. That is our on-the-spot polling system that will give us an indication on whether or not we will be able to repeat this. I will also say, with dry-eyed realism and transparency, that I think we are in for some challenging days ahead. Just like all of you, I believe we in public health may have some capacity issues in terms of having the time to take hours to prepare and do things like this. And it may not just be us. We may have other colleagues, because we have other individuals from our team and so forth that are available. And so we will take the feedback that hopefully you just provided with yes or no and take that into consideration and plan for the future. Lastly, and I'm going to give my colleagues a chance to say a quick final word, I just want to say thank you. Appreciate each and every one of you. I'm so thankful, actually, that we're doing this virtually tonight. It enhanced our capacity. The previous space that we had available would have limited this to 250. We are way past that. And we welcome your feedbacks. Please be gracious. None of us are professional TV hosts. We, under tremendous duress, did this in support of you. Probably could have been done better, and we welcome constructive feedback, not destructive feedback, constructive feedback, and we welcome that in case we will do something like this again. And having provided those words from me, I open up the floor. Any of my other colleagues have anything else to say in closing? Dr. Wooten, anybody?
I would just encourage people to read the health officer's orders and the latest guidelines on the CDC's website. At the bottom left, what's new?
Thank you. Thank you all. We appreciate you. We are here with you. We are making and living history together. God bless you and good night.